Hello, everyone. This is Michelle Dufresne, and I'm going to be covering tissue integrity with you guys. This recording is being done so that it can be placed online for everyone to see, since the original recordings did not occur as planned. So here it is, tissue integrity. The definition, as stated in your book, is this is a state of structurally intact and physiologically functioning epithelial tissue such as the integument and mucous membranes. Essentially, it's the integrity of mucous membranes, the corneal tissue of the eyes, subcutaneous tissue that's uninterrupted. This is an example of the A&P review, the epidermis, dermis, subcutaneous tissue. Underneath the fatty tissue would be your muscle and then the bone. So epidermis is made up of 7 layers of skin cells. Then we have our dermal layer, where our nerves are generated and blood vessels are starting to form. Sweat glands are lower in the subcutaneous tissue area. Oops. So the functions of the skin, to review again, to protect from invasion of microorganisms, control body temperature, has a psychosocial aspect, your body image, how people appear to you, sensation, storage of certain vitamins like vitamin D, control of evaporation of fluids, an absorption of certain substances that touch the skin, and also an elimination of body waste. So factors that affect the skin's integrity. In general, genetics, age, underlying health, and nutrition are the main things that affect our integrity. So the very young and the very old are at greatest risk for problems with skin integrity problems. The very young, like newborns, the skin is immature. It takes about 4 weeks for the skin to fully mature, and that occurs as the skin is exposed to the sun and the environment. And then the very, very old, as we grow older, we start losing layers of our skin, like the subcutaneous tissue is less, we have less collagen, so we lose elasticity of the skin. So all of that will impact skin integrity. Then chronic illnesses and the treatments thereof. So certain pathologies affect skin integrity, and treatments that will be used will also impair the skin's ability to function. Corticosteroids is an example of that. It interferes with the immune process, and the immune system is a big part of maintaining our skin integrity, and we'll see that a little later. Certain antibiotics and psychotropic agents will also impair the skin, like doxycycline, tetracycline, make us more sensitive to sunlight. And then certain chemotherapeutic drugs will affect us. Example would be methotrexate. And then tricyclic antidepressants will also have an impairment in skin integrity. What we assess, so assessment involves who does the assessment, when, how, and what. So a nurse is the only person who can do an assessment of the skin. When the most common time or easiest time to assess the skin on a patient would be in the morning when you're doing a bath, or other times may be when you're repositioning the patient or assessing them out of bed for whatever reason. Those are all examples of times that you can assess the skin. What do we assess and how? So we inspect the skin. It's important to look at skin folds, look at areas that are moist, like the perineal area, pressure points, any device that covers the skin, you want to remove it, like anti-embolic stockings, braces, medical devices. You need to remove those things so you can thoroughly see what's happening underneath them. We want to palpate for temperature, moisture, and skin turgor when we assess the skin. And then what we look for, we want to look for the color distribution or the distribution of lesions on the skin. Any evidence of edema, risk for breakdown, any tattoos, piercings, odors, and of course the skin turgor. So to the left here, you see all the major pressure points. What we call pressure points are areas where the skin is most vulnerable for pressure and shearing and friction injuries. So behind the head, occipital area, on the side, the ears, the temporal area, on the forehead, the tip of the nose, shoulders and shoulder blades, the elbows, the sacral area and the hips, the knees, ankles, and heels. These are the type of lesions that we're going to see. There are primary lesions and secondary lesions. So primary lesions are the basic morphology or disease pathology that's going on. So we'll see different types of those primary lesions. And here are the names. So a macule, a nodule, pustule, plaque, vesicle, and a papule. So a macule is just a flat lesion. A nodule is it's a slight raise to the lesion, and it's usually firm. A pustule is like a fluid-filled lesion. A papule is a fluid-filled lesion that's a little bigger than a pustule. And a papule will probably have more clear drainage, whereas a pustule will have a thicker, cloudy looking drainage in it. A vesicle or bulla, those are other types of fluid-filled lesions, and then a papule. So these are examples of our primary lesions. Secondary lesions are just the result of the inflammatory process associated with the primary lesion. So they'll have scales, scars, crusty oozing tops, or fissures and erosions that can develop. And toward the left side, this little graph talks about these primary and secondary lesions again. So like a macule, examples would be like hives, papules, and vesicles are more like cysts, bullas. We already kind of went over that. Wheals, another term used, and tumors, another term for a primary lesion. Okay. When we assess, also, we're going to assess for risk. So that's the main thing that you're going to do in the hospital when you have a patient every day, every 24 hours, and in some cases every shift. The nurse is responsible to assess for risk of tissue integrity problems. And we do this with the Braden scale. And the Braden scale uses specific characteristics that we look at that are listed here. So it'll look for sensory perception problems, moisture problems, activity problems, mobility problems, nutrition, and friction and shear problems. I don't expect you to memorize everything in each category, but you do need to know the major categories, which are sensory, moisture, activity, mobility, nutrition, friction, and shearing problems. The scoring system for it also you should pay attention to. So for someone who's at risk, a high risk would be a score of 13 or less. And so we want to know who's at risk. So this will help us identify those categories. In your book, it tells you how to rate them: low, moderate, and high. So anywhere between 15 and 16 is considered low risk. 13 to 11 would be moderate risk. 12 or less would be high risk. So those people who are at risk, they're at risk for friction, shearing, immobility, pressure, inadequate nutrition, anyone with a fecal urinary incontinence problem, decreased metal status, diminished sensation, any problems with body heat, like fevers, excessive fevers, advanced age, and chronic medical conditions. Those are major groups that you can kind of think of who are at risk for tissue integrity problems. Assessment, again. So these are other terms that you can use to describe the problems with skin integrity. So serous, serous sanguinis, and purulent, and any combination of these three words. So serosanguinous, purosanguinous. Serous is just a clear drainage, watery looking drainage that we see. Sanguinous means that there's blood mixed in this clear drainage. So it's a pink or red kind of drainage. And then purulent is that thick yellow or tan colored discharge that we would see in certain wounds also. Other things that we're going to assess include labs. So these are the major labs that we're going to look at: their white blood cell, the red blood cell, their platelets, and their coagulation studies. White blood cell is going to indicate whether or not there's an infection. Red blood cell will give us an indication of their nutritional status and perfusion status. So if they're anemic, that may indicate nutritional and perfusion problems. Platelet problems will indicate problems with bleeding, of course, and coagulation studies as well. And it is also an indication of their ability to heal. The overall CBC will give you an indication of that. The albumin level is important to pay attention to because it is going to give us an overall indicator of how well they may heal or create new tissue or new protein. So albumin is just a protein factor in our body. So the magic number to remember is 3.5. So anything less than 3.5 would be considered too low, and it may indicate malnutrition in your patient. Wound healing problems also. So wound cultures, we'll do cultures if the infection is suspected. And you want to pay attention to what's being cultured and then the sensitivity to it. So what medications is the bacteria sensitive to? What will kill it, in other words? So what is a pressure ulcer? So there are decubitus ulcer and bed sores are old terms that were used to describe pressure ulcers. Today, we are using the term pressure ulcer because it does describe more clearly what the problem is and the mechanism of injury that is involved with the problem. Pressure, basically. So injury to skin or underlying tissue, usually over a bony prominence, as a result of force alone or in combination with movement, like a shearing and friction problem, is a definition for pressure ulcers. So intact tissue requires only intermittent blood flow to maintain viability. So we're talking about the soft tissue around the skin and under the skin. Limited pressures, limited periods of ischemia are well tolerated by the soft tissue. So it's the reason why we are turning our patients at least every 2 hours, because the soft tissue under the skin can tolerate a decreased perfusion rate in those areas where pressure is maximized. For example, the metabolic rate of soft tissue is relatively low, and soft tissue is therefore much less susceptible to ischemia than tissue that has a high metabolic rate. So example would be comparing the skin to the brain, for example. Due to the slow rate at which oxygen is consumed in the soft tissue, a continuous flow of oxygen is not needed to maintain its viability. So intermittent delivery of oxygen by periodic restoration of blood flow is effective in maintaining soft tissue viability. So we can sit on our bony prominences like your buttocks for a certain amount of time before you start feeling that signal that says, oh, I need to move. And so you shift your body. So we're able to shift our body weight according to need. Our body tells us when that time limit is up and we need perfusion restored. So someone in bed who can't move for themselves or is sedated for any reason, they lose that ability to protect their skin. So turning the patient every 2 hours becomes important in that case. So to decide what is a pressure ulcer injury versus not a pressure ulcer injury. So we look at it in these terms: pressure ulcer versus hyperemia. So a pressure ulcer is considered a pressure ulcer when after 2 hours redness remains over a bony prominence and it doesn't blanch. So you see some redness to an area of the body and you try to blanch it and then it doesn't change color. It just stays red. No matter what you do, it stays red. That's considered a pressure ulcer. Hyperemia is when you see an area of redness and you lift the pressure off and you press on it and it blanches. So where you press it, it becomes white, and then when you release it, it returns to that pink colored, red color, and then it will subside eventually to a more normal color. So hyperemia is defined as redness to an area of the skin that it lasts no longer than 1 hour. So it remains red due to vasodilation. So that's perfusion being restored to that area, making the area red looking compared to the surrounding tissue. If it is blanchable, then we have sufficient perfusion still there, and it's eventually going to subside. That redness is going to go away eventually once enough circulation has been restored. So it's blanchable. It's not a pressure ulcer. If it's red and you cannot blanch it, it is a pressure ulcer. That means perfusion is not going to restore to that area. Those tissues have been deprived of oxygen and perfusion for too long, and the skin's going to eventually die off, and you will see evidence of that in the ulcer that forms. All right, so our goal is to prevent this from happening, to prevent pressure ulcers. And there are regulatory agencies that are watching this closely in hospitals because pressure ulcers are preventable and they are considered never events. They should never occur because all we need to do to prevent this is to move our patient, turn the patients, not neglect them. So hospitals will be refused payment for pressure ulcers that are formed while the patient is in their care. And stage 3 and stage 4 pressure ulcers are considered severe and serious reportable events. So we'll learn how to stage pressure ulcers a little later on. So they're never events. Pressure ulcers should never occur. Assessment of a pressure ulcer. So we're going to look at the location, then we're going to measure it, we're going to look at the color, we're going to stage it, we're going to look at the condition of the wound edges and the peri-wound, the healthy wound skin around the wound itself, integrity of surrounding skin, and then for signs of infection. Using the HYPER acronym, you can remember the signs of infection: warmth, swelling, pain, odor, exudate. Heat induration, which is loss of function, pain, and edema and redness for the hyper acronym. So to look at the location. The location is important because a pressure ulcer is defined as one when it is occurring in an area of a pressure point. So the pressure points that we looked at earlier, it has to occur over a pressure point for it to be a pressure ulcer. Okay, then we're going to measure it, the length, the width, the depth, the color of the edges, the color of the wound bed, and then stage it. All right. These are the most common areas where pressure ulcers occur. So the occipital part of the head, the ears, the shoulder blades, the sacral area, the elbows, the knees, and the heels, and the hip area. To take care of a pressure ulcer, we need to identify first those patients who are at risk, and then implement strategies to prevent them or decrease the risk. So some of those things are involving making sure they have a proper nutrition, making sure that their skin hygiene is maintained, avoiding trauma to the skin, and providing supportive devices on their bed, for example. So first, nutrition. So we want to make sure a patient has a high protein, vitamin-rich diet in vitamin A, B, D, and then also in minerals such as zinc and iron. Proper hydration is important to ensure perfusion, and body weight must be assessed for ideal body weight. We don't want them to be overweight or underweight. And then their serum albumin level. The serum albumin level, again, is a good measure of malnutrition or nutritional status. So if it's too low, then they have a problem with rebuilding new tissue, which would involve healing the wound. Zinc is critical for wound repair. And then high protein diets are needed to maintain our albumin levels, to restore new protein, to build new collagen and synthesis, and our proper immune systems functioning also. Skin hygiene, you want to make sure to assess the bony prominences again. Do not massage over those areas when you're cleaning the skin. You want to use a mild soap always. Moisturize the skin to avoid dry areas, and avoid using hot water. It should be room temperature water. Avoid using alcohol based barriers or moisturizers on the skin. So when a patient is incontinent, you should never delay cleaning those people. The more that excrement adheres to the skin, like urine or stool, that is going to be breaking down the skin more easily. So we want to clean that off of their skin immediately and then apply a skin barrier to protect it. To avoid trauma to the skin, this is a picture of a time clock, a turning clock. You'll see those used in certain areas of the hospitals just to remind anybody in that patient's room when it's time to reposition the patient. Every person that's taking care of that patient is responsible to help maintain that procedure. So elevating the head of the bed is important to consider. You want to avoid elevating the head greater than 30 degrees and leaving them in that high sitting position unless they can move themselves. If this person cannot move themselves, then you should not leave them with their head elevated so high. And the reason is it applies extra pressure to the hip area and the back lower lumbar area of the body. And so we want to prevent that from happening. So you want to lower their head to at least 30 degrees. Wrinkle-free foundation. So wrinkles in the sheets that they lie under can become pressure points and cause skin breakdown. So it's important to make sure that the sheets even underneath them are flat and wrinkle-free. The use of skin barriers like lotion gels and sleeves, even socks, can help protect the skin from friction and shearing as we move them in the bed. Positioning them, you want to lift, not drag them along the bed. So a draw sheet is important. If they can assist using a trapeze bar, they can help. Also, if they can assist using their feet and their legs, we want them to do that with assistance. And then turning them every 2 hours or more often, the better. So, but at minimum of every 2 hours, they need to be repositioned. So protective supportive devices. So overlays and mattresses is what we're talking about, or replacement mattresses with the fancy beds, with the air mattress beds, fluidized mattress beds, those alternating pressure point mattress beds. So that's what we're talking about. The overlays are, examples would be the blow up air mattresses that we put on them, or the foam filled gel mattresses that are placed underneath the patients on top of the mattresses. Protecting the heels are very, very important. And every patient in the hospital, you need to assess their heels, whether they're awake, alert, or not. The heels are a very vulnerable part that end up getting damaged easily. So make sure you're looking at their heels. It's easy to lift the heel off the bed. All you need is a towel or a blanket rolled and place it underneath their ankles to lift the heels off the bed to protect them. And then always remember the 4 Ps. You want to assess pain, position, potting, perfusion every time you walk in the room so that you're paying attention and preventing any injury to the skin. So here's examples of what can happen when we do not protect the heels or do not assess underneath a device that's being used on a person's limbs. You can end up with bad ulcers forming. See how simple it is using a towel to lift the heel off the bed. So there's no excuse for not protecting the heels. We want to caution patients about using donut devices. And you may see them bring in their own donut device because these were old things that were used because they believed that that was effective in reducing pressure ulcers to the sacrum. We don't want to use them, and we want to discourage patients from using them and educate them. The donut device was good to relieve pressure on the sacrum, but the places that the skin adhered to the device became breakdown areas. So that's why the donut devices are not safe to use. They caused more ulcers than prevented them. So now we're going to look at staging pressure ulcers. So this is just a reminder of the layers of the skin. So when we stage pressure ulcers, we're staging the depth of the wound. So you want to know how far deep is it cutting into? What layer tissue is it exposing? Is it the epidermis layer? Is it the dermis? Is it the subcutaneous? Or is it all the way down to the muscle and then the bone gets exposed? So that's what we're doing when we stage them. So this is why I'm showing you this picture to help orient you. So stage 1 is considered a non-blanchable erythema of intact skin. It's a partial thickness wound because it only goes through the epidermal layer of the skin. Then we have a stage 2, which is a partial thickness wound also, but we have a partial thickness again because it only goes down into the dermal layer of the skin. Then a stage 3. Stage 3 is considered a full thickness wound. It goes all the way through all the layers of the skin, the epidermis and the dermis. So the fat is now exposed in a stage 3 wound. A stage 4 wound is also a full thickness wound. It goes all the way through the layers of the skin. It also goes through the subcutaneous layer, and now we're exposing muscle tissue, and it may even expose bone. So a full, all the way through everything, the stage 4 full thickness wound. Then we have unstageable wounds. An unstageable wound is a pressure ulcer that you cannot see the terminal end, how deep it goes. It's unstageable for that reason. So the wound bed is covered with some kind of exudate. It's either sloughing, which is that it's loose discharge. It looks yellow, tin, gray, green, brown. Those are just examples. Or it could be eschar, which is a hard hardening of the discharge, and it's usually a dark color like black, tan, brown, almost like a shell kind of texture is what eschar looks like. Dried leather, I guess you could say, is a good example of what to picture it as. All right, so here's just examples of what the stages look like. So this is stage 1, erythema that does not go away and does not blanch. It's over a bony prominence, stage 1. Stage 2. So stage 2, partial thickness skin loss that involves the epidermis, or it can involve the dermis. So it's a partial thickness wound. The redness does not, there's a shallow crater. Abrasions and blisters are examples of stage 2 wounds. Then stage 3, it's a full thickness wound. And this goes all the way through the layers of the skin, and we're looking at the subcutaneous tissue in a stage 3 wound. It's a deeper crater. It's usually very wet, puts out a lot of discharge, and there may be what's called undermining. And undermining is just a weakened area made by moving material from its base and from beneath it to dig a tunnel underneath it somewhere, like over the edge margins of the wound. And then we have a stage 4 pressure ulcer, which is a full thickness wound that goes all the way down to the muscle, and even bone can be exposed. So in stage 4 wounds, you will see undermining again, the destruction of the underlying tissue surrounding some or all of the wound margins. It may extend in one or many directions underneath the wound edges. And then there's tunneling, which is a different thing than undermining. Tunneling is like a sinus tract that's created, and it usually is formed from the result of dead space within a deep wound. Abscesses can form, and then sinus tracts will form. We want to measure these complications. So for tunneling, you want to see how deep it goes and in what part of the wound bed it is located in. So you would use the face of a clock to describe where it is at 1 o'clock, 2 o'clock, 3 o'clock, and then how deep, how many millimeters is the track or how deep it is. Then the same thing for undermining. You would use the face of a clock, and then you would describe from what point the undermining begins and ends, and then you would measure the deepest point of the undermining. So now we're going to look at nursing care of staged pressure ulcers. For stage 1 erythema that's non-blanching, you want to clean the wound, and you want to use a skin barrier to protect it and protect the healthy skin around it. Sometimes you'll see a transparent dressing used. That's a clear dressing that's applied. These clear dressings have to be breathable. So oxygen needs to be able to penetrate the wound dressing. Or you may see what's used as a hydrocolloid dressing. So either one can be used. A hydrocolloid dressing that you've seen probably is like that spongy dressing that they may have put on a patient, may have had a wound, or they may be protecting a bony prominence by applying a hydrocolloid dressing to it. So you want to protect the surface is what I'm saying. And then you want to make sure you have the best surface for your patient to be on. You want a surface that's going to redistribute pressure. And that's what those overlay mattresses do. They're designed to distribute pressure so that there's less pressure applied to any one pressure point that the patient is lying on. That's the whole purpose of the fancy, expensive beds or the overlays that we'll put on top of mattresses. And then the best thing is to turn your patient frequently. Stage 2, pressure ulcer. Again, you want to clean the area and protection, because now we have an open wound. The skin is not intact any longer. So we need a dressing that will protect it. But we have to make sure that it's a clean wound. You do not want to put a dressing on top of a wound that is infected. So if it's not infected with a bacterial infection of some kind, we will put a simple dressing to put on top of it, like a hydrocolloid, or again, a clear transparent dressing. These dressings will provide protection, provide warmth, and allow moisture to stay within the wound bed. So it acts as the skin. It takes over the functions of the skin that was lost when the skin got destroyed in that area. So that's how you can think of a dressing. It's going to work to protect the skin like the area like the skin would protect it. So again, protect the skin, protect the margins of the wound, and use a skin barrier if you need to. Turn the patient frequently, and then provide comfort measures. So a stage 2 wound is very painful. It involves the dermal layer of the skin, and that's where all our nerve endings start showing up. So it's very, very painful, a stage 2 type ulcer. You want to assess for infection and necrosis. So we want to pay attention to the type of drainage that's occurring, erythema, swelling, pain, loss of function. All those signs of inflammation are the same signs for infection. The other thing about dressings, when they are applied to a patient, you should always have a date and a time that it was applied and initials of who did it. So you should look for that. And if you don't know, then it's probably safe to try and figure it out or replace the dressing. So you do know when it's due again to be changed. So a stage 3 with infection. Stage 3 involves the subcutaneous layer of our wound bed. With an infection, we're going to use a dressing that will help remove dead tissue out of the wound bed and fill the dead space. So a stage 3 wound is deep enough that it now has dead space that has formed. So to prevent complications like undermining and tunneling, we need to fill it. We need to fill that dead space with something. So the something that we can use is an alginate or a hydrogel. Alginates look like cotton. Okay, that's how I'm going to describe it to you. So it's a dressing that's made to absorb a lot of discharge, and it fills in the space that needs to be filled. Hydrogels are used when we have a lot of dead sloughing or necrotic tissue, like eschar tissue that we need to break down and get rid of. So the hydrogel will help liquefy this discharge and make it easier to remove it and debride it. So that's a way of debriding the wound using a hydrogel. It also fills the dead space at the same time. So when we have a lot of exudate, you need to think about cleaning the wound, getting rid of the debris, and making sure the wound bed stays moist and protected again. And watch for signs and symptoms of infection. The worst complication is sepsis with a stage 3 wound. So I kind of went over this already. With stage 3, we want to think about debridement if there's a lot of eschar or just purulent discharge, sloughing that needs to be removed. We have to debride it in order for the skin, for the wound to regenerate new tissue. New tissue that's regenerated is called granulation tissue. So we want to encourage granulation with stage 3 wounds. So the only way to do that is to debride it. So using a hydrogel would be a choice type of dressing to put in the wound bed. Now with hydrogels and alginates, those fit inside the wound bed, but we need to put something on top of them to hold those dressings in the wound bed. So you'll have 2 types of dressings. So 2-layered dressing is what you'll need when that's needed to be used on the wound. But we need to debride it, we need to clean it and encourage granulation tissue that way. So stage 4, pressure ulcers, the worst kind of pressure ulcer here. So we want to consider the surface area that your patient's on whenever you have a stage 3 or stage 4 pressure ulcer. We want to consider the type of bed. So this is the kind of patient who may need a fluidized or air bed that alternates pressure underneath them. Debridement, again, we have to debride the wound to encourage granulation tissue. There's different ways of debriding the wound. I just mentioned one, using the hydrogel, right? But there's other ways like Sharp's debridement, surgical debridement also that we'll use. We want to assess for undermining and also assess for tunneling. So these are really deep, deep craters that are created in the skin when we see a stage 4 wound. We're going to assess for complications of infection. They usually come in with an infection. And the worst type of infection is osteomyelitis, sepsis also. But osteomyelitis is automatically ruled out or ruled in with a stage 4 pressure ulcer. Okay. So let's talk about dressings now, a little more about dressings. So dressing's purpose is to protect from mechanical injury, protect from microbial invasion, provide a moist healing environment, provide warmth and insulation, absorb the drainage, debride the wound, prevent hemorrhage, and stabilize or splint the wound. So transparent film, hydrocolloids, hydrogels, and alginates, we've already mentioned all these types of dressings and examples of when to use them. So pay attention to the type of wound and what type of dressing is needed for that wound. Dressing choice depends on the location, size, and type, the amount of exudate, the need for debridement, and the presence of infection. Okay, all those things we went over already. So here's just examples again of pressure ulcers and the dressing. So here's a transparent dressing. It's an adhesive plastic dressing. It is a semi-permeable dressing which allows oxygen to flow in and out of the wound bed through dressing, but it's impermeable to bacteria and water. Protects against bacteria, and it also protects against friction, shearing, mechanical injury. So stage 1 would be the type of wound you would use it on. Okay, hydrocolloids can be used on stage 2 to stage 4 wounds. All right, they are those spongy wafer dressings. They're waterproof. They are occlusive. They seal the wound bed. They can be left on up to 10 days. So we want to leave the dressing on as long as we can to leave the wound bed undisturbed. We don't want to cause damage to the new fragile cells that are developing in that wound bed. The granulation tissue is very fragile. So we want to not manipulate that wound any more than we have to. Inside layer has particles that absorbs, exudate, foam gel over the wound. So that's important because it will provide wicking of debris from the wound bed, but it also will provide moisture at the same time to the wound bed. So absorbs small amounts of exudate, a hydrocolloid dressing, but protects against bacterial contamination, friction, shearing, provides a moist environment for healing. So it's good for stage 2 to stage 4 clean wounds that just need to granulate. It also can be used for autolytic debridement of tissue, like eschar. So the first picture up there is an example of that. The progression of that wound, you could see it as the next picture, it changed after so many days. And then at the end, it changed even more. You can see how it's clearing up more and more and more each time. So that's autolytic debridement that's occurring with this type of dressing, a hydrocolloid dressing that's been applied. Okay. So hydrogels are good for filling dead space in, and it is used to liquefy necrotic tissue that needs to be removed, sloughing tissue that's hard to remove. You would probably use a hydrogel to help with that. It hydrates the wound bed and it fills the dead space. So it's good for stage 3 wounds, like we said, and stage 4 wounds that need debridement. And also, like I said, it's going to need a secondary dressing on top of it. So it's going to be one of those layered type dressing procedures. Here's an alginate used for stage 3 or stage 4 wounds. An alginate is embedded with calcium, and calcium is what makes the material so absorbent. It can absorb 20 times its weight in exudate, so it's very, very absorbent. So very wet, high producing drainage wounds are going to need this type of dressing. It's not adherent. It washes away when you are ready to change it easily, and it fills the dead space. Supports debridement. So it's used for deep wounds, large wounds with a lot of exudate, like I said. Okay, so this is just a review of the dressings. Avoid transparent film on fragile skin. Reason for this, like our elderly patients, when you go to change that transparent film up, when you pull it off, you will pull skin with it. So you don't want to use that type of dressing on fragile skin. You would use a hydrocolloid dressing instead, because hydrocolloid dressings have a silicone kind of adhesive base, and it won't pull skin with it as you lift it off. It's also important to note that we use hydrocolloid dressings on non-infected wounds only. Hydrogels are used to liquefy necrotic tissue and sloughing away. Autolytics align necrotic tissue to self-digest. Our own immune system is what's going to be used to do that. and then alginates absorb and eliminate dead space. Other wounds we're going to talk about now, we're almost done, are lacerations, incisions, abrasions, contusions, punctures, and penetrating wounds. So a laceration is just tissue that's torn apart. It's usually an accident. Those people end up showing up right away for repair of a laceration. Incisions, with sharp instruments like a knife or scalpel, cuts open in the skin. It can be deep or shallow. Sometimes it's purposeful and sometimes it's accidental. Abrasions or scrapings, they're unintentional, involving, the dermal layer, usually, of the skin. Contusions are blows from a blunt instrument. They're closed wounds. They're bruised ecchymotic areas of where blood vessels that are damaged just leak into the soft tissue. Punctured and penetration now. So puncture wounds can be intentional or unintentional. They're open wounds though, created by sharp instruments. And then penetrating wound is an unintentional wound, like a bullet, metal fragment, that causes a deep wound through the skin. Classifying wounds, like I kind of did already, intentional or unintentional, open, closed, acute, chronic. Okay, we're gonna start there. Acute or chronic. Acute wounds are wounds that are less than 2 weeks old. So anything older than 2 weeks is considered chronic, a chronic wound. Chronic wounds are like pressure ulcers. They are expensive and they take a long time to heal. Wound depth is something we're going to discuss also. And it's similar to what we did with the pressure ulcers, looking at the depth of the wound damage. So how far does the wound base erode into the tissue? Is it epidermal layer, dermal layer, subcutaneous layer, muscle layer? Okay. And we'll go into those things. They're called superficial, partial thickness, full thickness, or penetrating in this case. So superficial would involve just the epidermis. Partial thickness would involve the dermal layer. So when we get down to the dermis, the body has to regenerate new tissue to heal. So it's gonna take longer to heal, and it's gonna leave a scar when you get into the dermal layer. Full thickness wounds go all the way through all the layers of the skin, epidermis, dermis, into the subcutaneous tissue. They're full thickness. And it could possibly go as far as bone, muscle, and bone. Penetrating wounds are always full thickness wounds. They are accidental, usually, and involve the muscle layers, usually, also. Then we can look at wounds as untreated or treated wounds. So with an untreated wound, you want to look at how we're going to approach care for an untreated wound. So those are accidents. They can be emergent. So the first thing you're going to do is control the bleeding. Then we're going to try to do tasks that prevent infection, minimize infection, and then control swelling and pain. Once those three things are addressed, we can now assess thoroughly what kind of wound do we have, what depth, what quality, and what type of wound do we have. So treated wounds, when they appear, it's usually usually not emergent. The wound, we're going to look at the wound and its surrounding tissue, describe it, and then determine the progress of healing. What stage is this wound in? And we're going to define the stages of wound healing in a few minutes. But to get straight first, what kind of wound we're looking at. So these are just examples. So an abrasion, a contusion, penetrating wound, and then partial thickness versus full thickness. The partial thickness wound involves, the dermis layer, and the full thickness wound is going to involve the subcutaneous or lower layers. So in the picture on the left, partial thickness. Picture on the right, you can see that it goes way below muscle into the looks like tendon area there, the bone, or bone we're looking at, I'm not sure. Looks like a tendon. So it's definitely a full thickness wound. And then here are examples again for you to compare all the different types of wounds we talked about so far. Starting with the pressure ulcers, how we defined depth of those wounds compared to our other wounds like we're talking about now. So superficial involves the epidermis, partial thickness involves the dermis. Anything below the dermis is considered full thickness. Now, what layer, what area of full thickness, you will have to look at the wound bed to determine that. Is it in the subcutaneous area? Is it at the muscle area? The fascia, remember, the fascia is a membrane that covers muscle groups. It groups muscles together and holds them together. So you may see the fascia over a muscle, or you might see it just go through the muscle all the way down to the bone, okay? And then this is just another example of looking at pressure ulcers versus a regular, what I call a regular wound. When we look at wounds, we're going to size the wound, we're going to measure, assess the depth of the wound, and then we're going to look for presence of undermining or tunneling, just like we did with the pressure ulcers. Color classification of wounds. This is just a way of helping you approach what we need to do first when we look at a wound as far as taking care of that wound. Red, if we see red, a red wound base, that generally indicates granulation tissue. We want to protect it. We see yellow, sloughing, that's discharge coming out of a wound. We need to clean that sloughing off. We might need to debride it or just clean it. If we can wipe it off, good, that's all we need. If it's black, then we definitely need to debride that wound. We always treat the worst signs first, okay? So we're going to treat the black tissue off first. We have to get that black tissue away before we can try and get the wound bed clear. If it's yellow, we got to clean that wound. That's the focus of that wound. It's going to be cleaning it, either debriding it again or just cleaning it. And then when there's red tissue, that's the healthy tissue. We need to protect it. So that's the focus of using the color scheme as far as determining what to do first, second, third. This is just a good picture. I probably should have moved it up toward the front of this lecture. It's showing you pressure ulcers and staging them. So it's just another way to review for pressure ulcers and staging. The one thing I did not mention when we were going over pressure ulcers was a deep tissue injury. So it's supposed to be suspected deep tissue injury. So the bottom picture here on the right corner is a deep tissue injury. It's not unstageable. Well, it is unstageable, but we call it deep tissue injury because it almost looks like a bruise. And some people may think of it as just a bruise. But if it's over bony prominence, it may not be just a bruise. A bruise will heal and go away. It has perfusion supplied to it still. If it's a deep tissue injury, that tissue does not have perfusion going to it, and it will continue to break down. And once it's broken down and opens up, then we'll see the depth of that injury. Usually it's a stage 4 injury, like it's showing in this picture here. The drawn out picture depicts the suspected level of injury with a deep tissue injury. Okay. All right, so debridement, different ways to debride. So the black tissue is the first thing we got to address. We got to debride it. We can surgically debride it, mechanically debride it, enzymatically debride it, or autolytically debride it. So surgical debridement, they go to surgery. In a sterile condition, it's debrided. Mechanical debridement is done at the bedside. Someone specially trained to do this will take scalpels and go into the wound bed and cut away the dead tissue. Okay. Enzymatic debridement is when we apply an enzyme in the wound bed itself, and it will eat away the dead tissue only. It does nothing to the healthy tissue directly, but it will break down the dead tissue. The thing we got to do when we use enzymatic agents is protect the healthy skin and the margins of the wound because from maceration from happening. Maceration is when the skin becomes overly moistened, and so it becomes more vulnerable to erosion and abrasions and friction injuries. So we need to protect it from that by applying a skin barrier. Autolytic debridement, we've talked about autolytic debridement is when we allow the body's natural immune system to break down the dead tissue by applying a dressing and leaving it intact, and it will eventually start to break it down. This is an image of what you're looking for. So I thought it was pretty neat. It shows you the edges of the wound and how it looks white. And you see the healthy red granulation tissue just below that white skin. That white skin is new skin that it just hasn't generated its pigmentation yet. And over time, it will become and look more like normal, healthy skin. So granulation tissue, we need to protect it. But the sloughing, the yellow stuff, and the black stuff is necrotic tissue we need to debride away. Okay. All right, so more about debridement. Chemical debridement. That's the enzymatic debridement that I mentioned earlier. So chemical debridement is what we do when we apply an enzyme in the wound bed to break down the dead tissue. Collagenase is the only agent that's used today on the market for this purpose. Autolytic, body's own immune system, enzymes will come in and break it down. So surgical, Sharps debridement is when surgery, we bring them to surgery, or Sharps debridement at the bedside, they cut away the dead tissue. Mechanical debridement. Mechanical debridement is a new one I haven't mentioned yet, and we can do this a couple ways. Applying wet to dry dressings is one way. It's an old, outdated procedure, or scrubbing in the wound bed, the dead tissue away, or applying irrigant by using a 35 cc syringe with a 19 gauge needle. You applying 8 PSI to the wound bed, and that will help break loose the dead tissue. And you still see that ordered. We used to do it all the time. It's not so often anymore used in the hospital units, but you'll see it in wound care centers being done. So wet to dry dressings are usually applied as a temporary condition when we have to replace a dressing and there's a problem. So we'll use a wet to dry dressing until we can get the therapeutic dressing back on. So generally that's what we do with wet to dry dressings. We don't really use it to debride anymore like we used to. So the heel. Eschar, this is a good picture of what eschar is. Look how it looks leathery, and it won't heal unless that dead tissue is removed, necrotic tissue is taken out. Oops, sorry. So knowing when it's safe to remove the eschar is what's important. If the extremity is not well supplied with perfusion, circulation, then eschar is, in this case, being protective of the wound bed. You don't want to remove it. You want to let autolytic debridement take place. So you'll see physicians leave the eschar on the wound, and that's the reason why, because that limb does not have adequate circulation, so that the eschar now is a protective covering for that wound bed and will let autolytic debridement take place. All right, types of dressings that are used with these type of wounds. Silver, AG is silver. So we'll use silver impregnated dressings to apply to the wound beds when we suspect infections going on in a wound bed. You don't want to clean the wound bed with a harsh chemical like peroxide, hydrogen peroxide, or betadine. Those items will destroy the granulation tissue that's forming. So that's why saline, normal saline is the safest thing to use to clean a wound bed. Wound cultures are used when we suspect an infection. You want to collect the culture sterilely. In your book on page 840 to 841, skill 36.1 goes over the actual procedure of collecting a wound culture. You don't have to necessarily be gowned up and goggled and masked to get a sterile wound culture. What needs to remain sterile is the item that's going to get the sample, and the device you're going to place it in has to be sterile for this to be collected. And you want to do it generally before an antibiotic is applied to the wound bed or given to the patient systemically. All right, so antibiotic powders and ointments are used. Silver impregnated products I already mentioned. So polysporin was an example of the antibiotics that can be used to cover wounds that are infected. A wound vac is used in a large chronic wound. So they'll use a wound vac when the patient doesn't have a good circulation to that area, or for some reason they just have poor healing, which could be for a number of the reasons we already covered. So wound vac is put out by KCI. It's the only company in this area that carries them in our area, and that is what they look like in this picture. They have two types of sponges, the black sponge or the white sponge. They will place the sponge in the wound bed. It's not a sterile procedure. And then cover it with an occlusive clear dressing that seals it in. This is connected to the wound vac tubing. It applies pressure, negative pressure to it, and sucks out the drainage. The wound vacs are very successful. They do speed up healing time, and it provides everything that we discussed the dressing would provide. It wicks away the drainage. It provides a warm, moist, insulated area for the wound bed to regenerate granulation tissue. So it's very good. Our task as a nurse is to measure the output that's being taken out every shift and to make sure that the dressing remains intact and sealed. If the seal breaks, it will not provide any suction. So we'll have to replace the dressing, either cover the sealed, the crack or the leak, or replace the whole dressing. If you have to replace the whole dressing, you're going to take that sponge out and put a wet to dry dressing in the wound bed until that can be reapplied. These are drains that are applied to our wounds surgically. So a surgeon applies these to the wound bed. And the first one in the left upper corner in the orange picture is called a Jackson Pratt. You may also see them call them grenades. They need to be compressed, like in the middle picture. The middle picture, it's activated. When it's collapsed, it's activated, it's applying suction. When it's open, inflated, it's not applying suction. So you need to activate it and make sure it stays activated. Our job as a nurse is to make sure its integrity is maintained, that it's in place securely and safely, and that the device is activated. And at some point, we're going to measure our output every shift and then reactivate it. The picture on the right middle is called a HEMOVAC, MVAC you see on the top. HEMOVAC is another type of drain that you'll see surgeons put in when they have a dirty wound that they know is going to produce a lot of drainage. They'll put a HEMOVAC. So we have to do the same thing with HEMOVACs. You need to make sure it stays activated. In this thing, there's a spring. So you got to compress the spring and keep the top sealed. That is going to activate it. Every shift, you want to empty it. So you want to apply slight pressure to the top of the HEMOVAC, open the seal, and then slowly let the spring come open. Empty it, and then reactivate it. The hand at the bottom has a Penrose drain, and you see examples of Penrose drains on the table in the middle of the screen. Penrose drains are also inserted, and they will come with a bulky dressing wrapped around the wound when they have a Penrose drain. Our job as a nurse is to change the dressing when it's saturated with drainage. You don't want to leave a wet, dirty, saturated wound a dressing on your patient. So it'll be changed when it gets saturated. And you would describe the type of drainage and change the dressing. So here are the principles of wound healing. These are important. We've talked about them already, somewhat. Intact skin is the first line of defense against microorganisms. Surgical asepsis is used in caring for a wound. A body responds systematically to trauma of any of its parts, which is important to understand. The body considers any kind of wound trauma, and it's going to respond to trauma the same way, as if it got run over by a Mack truck or just got cut by a little paper cut on your hand. So it's still trauma. Your body responds the same way systemically to it. An adequate blood supply is essential for normal body response to injury. Normal healing is promoted when wound is free of foreign material. So clean wound bed is the stress point here. The extent of damage and the person's state of health do affect their healing process. So how they feel about the wound makes a big difference in how well they'll heal. Response to wound is more effective if proper nutrition is maintained. So maintaining adequate protein and calorie count is very important to maintaining a healthy healing wound. Factors affecting wound healing, again, developmental considerations we need to think about, age differences. Children and adults heal differently. Generally, if you're a healthy child, you'll tend to respond quicker. Your immune system responds quicker. All your body systems respond quicker. And so healing time may be a little faster. Adults, as we grow older, our responses physiologically change. So our healing ability may change and take more time to heal. And then chronic conditions you have to consider as well. So your overall health status will make a difference. What kind of medications you're on will make a big difference. Adequate blood flow is essential. We said that already. Nutritional status, major important thing. Adequate nutrition is very, very important. If you don't have enough protein intake, you will not have enough to build new protein, as well as adequate calories to fuel the energy that's needed to create new tissue. Then your lifestyle will play a part in that. Also, the wound's condition and stress on the wound itself. We're going to talk about that a little more. So how do wounds heal? These are the three basic ways wounds heal: through first intention, second intention, and tertiary intention. First intention is when a doctor sutures up a wound. The edges are sutured together, and that's primary intention. Secondary intention, the wound edges are sutured or brought together, but for some reason, they broke apart. So they start opening up. That's when we have to heal through a longer process. Granulation tissue will need to form, and there are other problems, like we have to guard against infection now because it's open, it's not closed anymore. The scarring will be a lot bigger because it has to granulate to heal. So it takes a longer time, bigger scar, possible complications, infection with secondary intention. Tertiary intention is when the provider has a dirty wound and they do not want to close it immediately, or it's impossible for you to bring the edges together. So it will have to heal through tertiary intention in that case. So again, it takes a lot longer. The wound stays open and granulation tissue has to form and slowly build new tissue and fill in the space that's missing until the edges are able to come together. So at some point, the physician will decide it's safe to either close that dirty wound because now it's clean, or now we have enough tissue rebuilt that we can bring the edges together and close it. So at that point, the edges are brought together in a tertiary intention healing wound. So it still does take a longer time to heal. You have all the complications again of an open wound to worry about. All right. So example of primary and then example of tertiary healing. Secondary healing. And then on this page, you see tertiary healing. The leg, the thighs, tertiary healing. I wrote the wrong thing here. Okay. Phases of wound healing. At the end, phases of wound healing. So the first phase, real brief overview of the phases of wound healing we're going to do. The first phase is the inflammatory phase. The first week, basically. Hemostasis and phagocytosis. That's the primary function in the first phase of wound healing, the inflammatory phase. So you get a cut, and your body's going to want to protect it from bleeding out. That's the first thing that happens. So platelet cells are rushed to the area to form a clot. This happens from the injured tissue opens up, those cells open up, and the chemicals that are released trigger this response. So the platelets rush in and clotting takes place. Then following the platelets comes white blood cells. So phagocytosis is going to be the second part of the inflammatory phase because it needs to, again, protect the body. So it's going to wall off the invaders and then destroy them. So phagocytosis takes place. The white blood cells come in, the leukocytes, and then the macrophages, and then so forth and so on. The immune system takes over. Proliferation phase is the next phase. So after the first week or so, till about the end of the first month almost, is the proliferation phase. So proliferation is a key word. It's rebuilding tissue. So if we have a clean wound, the body's going to start rebuilding cells, skin cells or tissue cells. So new blood vessels will form. Granulation tissue is built up. The wound begins to contract or become smaller. The edges are starting to close together, and resurfacing is taking place at the end, where you're starting to see more normal looking cells. So epithelialization is the term we call that. Collagen is now going to start to begin to build up in that wound. When we're at that stage, we're about to enter into the last stage of this process, which is called the maturation stage. But in this proliferation stage, this is the most vulnerable part of a wound for healing. If it's going to have problems with intention, wound intention healing, it's going to be during the proliferation phase. So if we have a first intention where the sutures are pulled together, edges are closed, and the wound is healing, and we're in the proliferation phase, this is the most crucial point where the wound could start to get injured and open up. So it's not strong, but it's beginning to rebuild those tissues, and complications of incisional healing can occur most likely during the proliferation phase of wound healing. So the third phase is maturation or remodeling. So from about day 21 to up to 2 years, it may take several years. This may take and can occur. Remodeling is when a scar forms. The scar forms and it rebuilds and tears down that scar until it's finished. And this tissue, to note, is never going to be as strong as original tissue was. That's the big part about it. Okay. Okay, so now we're going to look at complications of wound healing. Infection, hemorrhage, and wound disruption are the major complications that we're going to mention. So infection causes delays in wound healing. Hemorrhage is when there's a collection of blood beneath the surface of the skin, and that also delays wound healing. That's when we need to pay attention to the drains that our surgeons are putting in place of those wounds. So those Hemovacs, the Grenades, Jackson Pratts, the Penrose drains. If they start putting out a lot of discharge, you want to pay attention to what kind of discharge it is, what it looks like, the amount that's coming out, because it's real important to note the amount. That may be an indication of hemorrhaging going on in that wound. Then wound disruption. There's two major kinds of wound disruption: dehiscence and evisceration. Dehiscence is when there is a partial or total rupturing of a sutured wound. More likely, this will occur day 4 or 5, which is during our proliferative phase of wound healing, right? Day 4 or 5, postoperatively. So when that happens, it's a pretty emergent situation. The patient needs to be brought back to surgery, of course. And before that, you would want to protect that wound. So you would take a sterile dressing which is saturated in normal saline and cover that wound until the patient can go back to surgery. Evisceration is a type of wound disruption in which the wound has opened up and now the organs are protruding out of the wound. So it's extremely emergent when that happens. You would do the same thing, notify the surgeon that person needs to go back to surgery, but we need to protect the wound. We need to cover it with sterile gauze saturated in normal saline until that patient gets down to surgery again. What are some causes of wound disruption? So someone who is obese, who has poor nutrition, who overexerts themselves, or put stress on the suture line, like from coughing or vomiting or straining to go to the bathroom, for example. Those are all different ways that you can cause pressure or stress on the suture lines. So those are situations in which we want to avoid wound disruption from occurring. We would take special precautions in those cases for patients who are overweight. We want to teach them how to decrease the stress applied to their incision line by splinting the incision with a pillow or with their hands when they're repositioning themselves or walking. In some cases, there's just failure for the sutures to heal for different reasons. For example, a patient who's on a lot of steroids that are systemic, high dose steroids will impair skin and wound healing. So that's just an example of a case to think about. And on this page is some links that you can try to look at examples for dehiscence and evisceration. So nursing care for wounds, again, we want to maintain moist wound healing environment, provide sufficient nutrition, hydration, protect them from infection, and proper positioning to decrease the stress on the wound line or incision line. We want to consider pain control, anxiety, fear, change in body image for our patients. So those are all different areas or concepts to think about when you're looking at your care plan. Prevent injury, prevent complications, and promote healing. Those are our goals with wounds, with any kind of wound. So first we want to assess people, those who are at risk for wound dehiscence or evisceration, infection, people who are at risk for skin integrity problems. We want to observe the patient and interview the patient to get information about how they take care of their health overall, their general health and well-being. Physical examination, you would look for evidence of problems with the skin or potential risks for problems with wound healing for surgical patients postoperatively. Diagnostic tests we would look at would be our white blood cell count, our coagulation studies, our indicators or markers of nutritional status like our albumin. We want to pay attention to independent interventions that we can do as nurses to prevent skin integrity problems and wound care or wound healing problems that we outlined already. And then collaborative therapies. We're going to collaborate with other professions like PT, dietary, OT, respiratory, to help prevent complications from wound healing. And then pharmacological therapy. As ordered by our doctor, we would give them antibiotics as needed, control their pain, and provide any services that or medications that would promote wound healing, like vitamins, minerals, hydration, and things like that. These are the diagnoses associated with skin integrity problems. Risk for pressure ulcer, risk for impaired skin integrity, impaired tissue integrity, you could say, even. Risk for infection, or if they have an active infection, and acute pain. Okay, so at the end are the questions that we went over in class. If you have any questions about anything, please just send your questions in the discussion board. I'm going to look at the discussion board this week and start addressing your questions. So I hope y'all enjoyed this recording, and good luck on your test, and love the skin you're in.